subscribe. If this is your first time watching one of our webinars, QNCC sits within the Royal College of Psychiatrists and sets standards for community CAMHS services. QNCC works with member services to identify examples of good practice and areas for improvement. We'd also usually offer a series of events and networking opportunities. So, in the absence of face-to-face contact, the aim of these webinars is to provide a space where teams can share experiences and discuss new ways of working. Before I hand you over to our presenters for today's session, I've just got a couple of housekeeping points to go through. The session is a live event, therefore your microphone and camera will be turned off unless you're a speaker. The webinar will be recorded and uploaded on the CCQI webinars webpage. Please use the chat function to ask any questions, and you can vote for the ones you want answered the most. Use the chat box to let us know if you would like any specific topics covered in future webinars. So now I'm going to hand over to a QNCC Advisory Group member, Eduardo Szaniecki, and his colleague, Yoko Totsuka, who will be speaking about their experiences of managing the COVID-19 crisis within the community CAMHS services at North Camden Community CAMHS.
This bumpy start, I think, is a reflection of really what's the latest, the last few weeks, really. And so if you can hear me all right, thank you very much, Aaron and Charlotte, for today, the QNCC group. And Yoko and I, as Aaron introduced, we're not in the same room. And so we made some slides to help with, help a bit with the orientation for the two of us and for you who are watching. The downside is that we can't be, well, we're not in the same room, of course, but we can't be on the screen at the same time. So it may be, it may be a bit bumpy at times, and but the talk and the slides will be uploaded, so if we don't cover everything, then you can always check later on the website. So we thought there is a bit that we want to cover that Yoko and I thought, and just as I start, really, we thought that we would I'll talk a little bit about the wider context, because it is, of course, hard not to and to avoid, the sheer size of what we're going on. This has been an extremely frightening experience, and we've noticed a huge variation in the way people responded to the crisis, what's going on, and we thought. The importance really to be aware that people have become aware really of very much of their own mortality, but also about the many losses that people have been experiencing, not just in terms of close ones, but also losses in different levels, like financial losses and financial worries. And I think that as we go and we're beginning to really experience this anxiety and fear about the next phase, and we start talking about the second wave and how services are going to look like and what the implications to our lives. And I think what we added there really in terms of opportunities is that maybe not for us not to lose track of the opportunities that the current situation is beginning to show to us, and I think we're going to be talking about some of that later on today. So what we thought we would cover would be very much an outline of our service here at Tavistock and Portman NHS Trust, where Yoko and I work, where we sit in, the Camden Community CAMHS. And then we want maybe we begin to move on to think about what has changed for us and how we evolved as a service, and then maybe look into some specific issues because we are in an organization that has a heavy psychotherapeutic and education and supervision and training weight. So we want to look a little bit about specific issues related to that, and then moving on to some lessons that we learned, but also learning really as we are going along, and some implications for the future. So like I said, if we were together, it would be far more conversational style, but I wonder, Yoko, whether you could do a bit of an introduction about the service, the Camden, but also the specific team. How do I transfer to Yoko?
Hi, I've just unmuted myself. Can you hear me? That's great. Hi, my name is Yoko Totsuka. I'm a Family and Systemic Psychotherapist, Counselling Psychologist, and Clinical Service Manager of North Camden Community Team. And so I work alongside Eduardo in the same team, but we are part of a larger Camden CAMHS service. So I'll give you a little bit of context. So I just wanted to show you where we are in London, and we are just above the city. We are geographically relatively small borough. But we are quite long in terms of from north to south stretch. So community teams are divided into north and south teams. And we north team is located within the Camden, north part of Camden around Hampstead, and located within Tavistock Centre. Could we go to the same next slide, please? Thank you. So as you see, our population is not humongous compared to my previous CAMHS job. The CYP population is quite small at 45,000, and the estimate is around 4,000 CYP 5 to 16 years would have diagnosable mental health condition. Could we go to the next slide, please? Thank you. So I just wanted to give you a little bit of context of Camden CAMHS. So we are part of a large children, young adults and family services within Tavistock. And we at Camden CAMHS, we work with children, young people from 0 to 17 and their families. We have both clinic-based and outreach services. As many other CAMHS probably, I'm sure you're the same, but we receive referrals from GP, schools, health services, local authority and self-referral. And what's unique at Tavistock is that as part of our trust, we have a large Department of Education and Training, and many of the clinicians in my team have teaching roles within Tavistock. Okay, next slide, please. So Camden CAMHS are divided into several different teams. So we are one of the two community CAMHS, so the generic CAMHS team, if you like. We have separate hospital CAMHS teams which do neurodevelopmental assessments and eating disorder and then other services. So we do a range of things, emotional problems, behavior problems, but we also would see children, young people with fairly generic issues, mixture of problems. And we have case adolescent intensive support service, and they work with young people intensively. And their cases come straight from hospitals, so their main role is to prevent hospital admission or transfer cases safely to community, and they do a great job. We have two teams which are co-locating with the local authority services. So our colleagues in whole family team, they co-locate with children's social care, mainly child protection teams. And we have a separate looked after children teams who also work in the local authority venues, and they have actually maintained their presence throughout this time. We have clinical intake team whose role is to do information gathering and signposting. So this is a new setup for us, which was set up probably about a year ago to make our intake process more efficient. Separately, we have mental health support team. This is part of Trailblazer initiative, and they work in schools. And they have actually maintained services and developed various things such as webinars, and then still offering services digitally and by telephone and so on. Camden CAMHS managers meet twice a week for referrals meeting, and we are developing more consistent referral criteria and so on as we speak. Okay, so we I'm not going to go into too much details, but as you see, we do a range of things, which I'm sure other community CAMHS typically do. We have one full-time equivalent post across two community teams. One person who is employed by Camden and Islington Trust, and whose role is to support parents' well-being, and they take on separate parenting psychological work. What's also unique in Camden is that we have CAMHS clinicians in all the schools. So currently we're facing a bit of capacity issues, but the ethos is that in each school in Camden will have named CAMHS clinician who will do all sorts of things, sometimes direct to work, but consultations and assisting referral process. And we have maintained links with schools during this time.
Well, thank you, Yoko. Shall I kick off from this one? Can you hear me? Can you continue to hear me?
Yeah, we can, Eduardo.
Thank you, Yoko. I think that's quite a useful overview, really, about what's clearly, you know, very intricate services and quite connected, really, a connected network that we are going to be talking a little bit more later in relation to how it changed. But I'm just thinking about what has changed in terms of the work environment. I think I will not be alone, really, to say that we all have been experiencing a massive information overload, really, in terms of emails and documents to read, protocols and guidelines to adjust and readjust. And I think that has been really momentous, really, the amount of information that we have been having to adjust. Then another one really is that we've noticed the access to services and the referrals. We saw a clear drop right at the beginning, and I think that seems to be very much the same, very similar to many services, including A&E presentations. But the usual referrals coming from GPs and schools, partly because of the situation, they were closed, really went down. And we are beginning to see, I would say, over the last maybe 10 days or at least 2 weeks, them beginning to pick up again. I think that we've noticed a big change, really, in the agencies that we work together with, like social care and other agencies who provide, for example, therapy and other services. They also were either closed or going through the same type, a very similar type of situation with information having to adjust. So we had a very clear, that was really striking, really, how much we had to, the change that we had to adjust. And the physical space is that, I mean, on one hand, gradually we had this a reduction in number of people around, and the place, which is relatively big, became quite empty, really, and with a lot of space for those who were here, like sometimes we came, but also we had at times really to think about even the safety of the place, because it was actually quite empty. Is anything about that, Yoko, that you like to add? Otherwise, I'll move on. Not. And in relation to the clinical environment, to the clinical practice, we've noticed a very a clear change in the pace of the way we work, because I think the change to face-to-face to remote, a big shift, and also in keeping with what I just said in terms of emails and having to set up Zoom sessions and Zoom meetings to the way it was. That was a big shift, really, having to adjust and readjust to, including, in relation to this webinar, really, the IT issues, which I think we're going to talk a little bit more later. So that was a big change. And we've noticed for some time a lot of people, really, all of us, talking about how it was really tiring, really, to be doing many Zoom sessions, telephone conferences, telephone calls, having to adjust to the lack of sound or lack of image and poor connections. And so there was a sense of big uncertainty, really, not just about the IT connections, but also about how things were going to go. But I think I like to, maybe what I put on in brackets is that we also saw a huge resilience in people, and also quite a lot of friendship and coming together really as a big group and small groups as together to try to address really some of these issues. And the last point here on this slide is about that we for those people, for those young people who were being referred, we've noticed there was some, not just being referred, but also how to manage some of those situations with young people with multiple risk or comorbidities, and young people who, for example, had dysregulation and impulsivity, and all of that on top of COVID and the need for social isolation. It's interesting to think about that now, because at the time that Arum and I were talking about this webinar, things already changed, from like 2 or 3 weeks ago. Things are already changing, and they are changing really quickly. I wonder, Yoko, whether you like to talk about the workforce and staff, or the things that have changed, and I can add a little bit at the end.
Yeah, sure. Yeah, I think staffing issues, workforce issues were absolutely massive. Previously, I actually didn't know where people lived. I've been in my post for about a year, but then I hadn't actually gone into the details of people's commute, for example, and family circumstances until this situation arose. So we had, I'm sure as other trusts have done, we had a systematic approach to the initial phase of sort of adjustment in terms of establishing who can work from the clinic and who can't. So I probably have about 5 people who are having to work from home due to health issues and vulnerability issues. And the trust has just launched the second phase of that in preparation for thinking about how many staff members can actually come back to the building when that's possible. So we already lost quite a few people who could still work from home but couldn't come in. And we set up a minimum staffing rota system. So, for example, from my team, there's one person on the rota every day, and from several teams, we form a Camden CAMHS hub with several people. But that would obviously require coming into work, which not everyone could do. There was a lot of anxiety about coming into the building, so there was numerous discussion as to how that could be possible. The borough actually made parking free, and also Tavistock itself made parking free, so that actually made things a bit easier, but it might become a challenge from now on when more people will be travelling in the community in general. There were some staff who went off sick. One person actually tested positive 3 weeks after she started to develop symptoms, and there was a constant sense that we just didn't really know enough about this virus, and a lot of us were reading or watching news and so on, and trying to learn as much as we could and share it as a team. So initially we actually set up a daily briefing meeting. And initially it felt as if any plan we made 10 minutes ago could potentially change very quickly, and that actually definitely slowed. So we gradually reduced both managers' meetings and also teams briefing meetings. So currently the managers are meeting twice a week. As a team, we are doing something similar, quick touch base and any updates from the trust or management. Separately, there is a trust briefing, which I'm sure Eduardo will come to later. But it was a very difficult transition, especially when the lockdown came in. We had already been having most of the meetings and quite a lot of supervision by Zoom, because we started to realize that any activity we do in shared space was potentially risk. But from the 23rd of March, we established a system that, apart from the people on the rota, other people can work from home, and then we started running around trying to find every single laptop, and the business manager did a massive amount of work trying to establish the number of equipment, and initially we didn't have enough to go around, and gradually we probably became better equipped. but that was quite long and but also very speedy process.
Yeah, yeah.
And then
Can I just,
yeah, go on.
no, I should just, I'm going to add a couple of things about those issues, which on the slide, this is really useful, Yoko, just thinking. One thing I remember right in the beginning, it was this, when we really, went home, working from home and trying to bring laptops, was this, it generated a sense of isolation, and the people were not connected. I think we heard partly to do with connection itself, really IT-wise, but also the sense that they were not in the building, really. They're not at their work base. And that was a big change, really, because people, I mean, I remember thinking and feeling about that, really, you were somehow disconnected from your usual place and your usual work. And the second one is about gradually people, of course, we had to find space in our houses and our homes or places where people live, and having to deal with privacy and having a comfortable chair, to actually creating the headspace to do the work that we do. The nature of the work that we do from a place where you normally don't do that, really, and that is there was a quite situation at odds, really, there in terms of the headspace and how people felt about working from home. But I actually think that is also changing, because it's amazing that people getting used to and readjusting to that situation.
Yeah, absolutely agree. A lot of people are talking about how they were just doing endless overtime. It was so hard to create the boundaries. So some of us actually prefer to come in, and we're probably lucky enough to have easy commute. But then some of us were coming in because we prefer the structure. So structure of the day was a constant challenge. And initially, because we were having to contact all the clients to get an update, just to check in, are they okay, and also explain how we might actually work differently from now on. The amount of work was absolutely massive, and the number of contacts in April was quite a lot more than usual, and I think it settled slightly in May. And then people kind of started to kind of report that, and it seems a bit more containable now. But I think this kind of idea of proximity between work and home was a real challenge. And then I found myself talking with people a lot more about work environment. So some of the things, such as performance issues, to a certain extent, I had to put them aside just to make sure that people are okay, equipment, some of the health people I actually had no idea before. And it could have been really simple things like, when 3 children and a partner is working from home, do you have enough data on your internet system? And also, do you actually have space? I actually had a colleague who was saying the only space she had the privacy would be bathroom. With the partner home as well.
I was thinking about what you were talking about, the brief meetings that we set up, in the beginning. The North Camden team, we set up 3 meetings a week in the morning. Like he started off as say hello and see how people are, really, and to actually touch base with each other, and then gradually moved on to something else, so more sort of business meeting. But what we've noticed is that actually attendance in meetings increased. People wanted to be part of some of those meetings. Also, it's fair to say that some of these meetings were for 15 minutes and half hour, just really to touch base and see how everybody are, and to outline the day and then on the week. But also we've noticed that people could attend more meetings, relevant meetings that maybe before they couldn't. Another thing that I just want to make sure we say is about people's professional development. Some of them were put on hold, especially in the beginning, but clearly people wanted to continue that, and this is beginning to happen. let's see, in terms of organization, I think we touched on that in terms of, or maybe we can say a little bit about the hub, because we created right at the beginning a hub where the Camden service came together to operate from, and where things were going to be centralized, referrals were going to be centralized, and decisions in terms of urgency were made. But we kept the same structure behind that in terms of referrals and allocation. But the hub has been considered a very important move. Is there anything you want to say about the hub, Yoko?
Yep. So as I said before, that's our minimum staffing, and I think it was a very helpful thing to do. And I can't take the credit for it, because it was a kind of bigger piece of work that we were part of, but we were not in charge of necessarily. So it was set up very quickly, and there were times it was very quiet, and some people are questioning whether they need to come in, but we really sort of held on to the minimum staffing level of 4, 1 senior clinician and 3 clinicians from each team, and so on. And then it was just a way of being available in case some really urgent cases come in and we need to see people face to face. So currently at Tavistock, we are only seeing amber to red high-risk cases face to face. And we set up a clear procedure. People need to speak to the manager to see whether it warrants it. And then we will explain to the families about the fact that we'll be wearing PPE when they come in. We'll be offering them masks as well, so that the clients can make informed decisions about coming in. And there are a couple of designated clinical rooms, huge rooms, where we can see clients when we need to. But there is a new room booking system. So after each family is gone, the cleaners will come in and clean the room. So that seems to be operating really well. And I think currently we probably have about 5 to 10 cases seeing face to face. So currently we're thinking about what the next phase might look like and trying to scope for cases where there is no risk and urgency, but clients are either unable to make use of the video or telephone meeting, and then possibly prefer face-to-face for whatever reason. But we are not there yet. We're currently still making assessments of the building. So one thing I wish we had been able to do is the fact that our clinical room is actually quite far into the building. And I was talking to a colleague of mine who works in another trust and another CAMHS, and they designated 2 clinical rooms closest to the entrance. But in terms of the design of the building, it didn't work. But that's one thing I really wish we had been able to do.
Okay. I just thinking about some of the things that are having to wait to be put in place, and which may resonate with many organizations and other CAMHS elsewhere, really, because of course with this we were caught in several plans that things were going to be established, and from say new team structure or to thinking about a new way of doing business or governance meetings. So there have been quite a few things that have been put on hold for now, really, from very basic stuff to actually large ones. And I would like to just emphasize, the IT issues, which have been absolutely huge, including the fact that IT people themselves were in lockdown, so they were not in the building most of the time. They could actually address some of these issues remotely, but it was certainly one of these things that you often either go to them or they come to you to see something often close to you, and that stopped, and that was quite challenging as well, really, and including the upgrading, really, that it was caught in the middle. Let's see, in terms of how the service, what actually we involve in. Well, we talked a little bit now, we talked about the CAMHS hub, and you said, Yoko, about the face-to-face outpatient appointments. We talked a little bit about this, the team briefs, but the briefs were at various levels within the organization, because we had, what we were talking is about the team briefs, but also we had the senior leadership briefs, which was, I think, was 2 or 3 times a week as well to begin with, but now it's less. And the whole trust briefs, which were quite important to say, really, was quite relatively quickly settled with this new way of working. Was quick to set up, and people got into sort of logging in pretty quickly to be part. And again, it was a sense that you were part of the process. That was quite important, really, that you knew what you knew and know what's going on and part of the whole process. In terms of the staff support, do you want to say, Yoko, about this in mind, the online or together in mind? We have a little bit later on a slide about support.
Yeah, I can say a little bit about it, but I haven't actually made use of it myself. So there have been some resources that are available to staff for staff well-being. And recently, Tavistock launched what's called Education in Mind. We were specifically asked to collate resources for school staff, because we work very closely with schools. So there is attention to staff well-being quite a lot. I was listening to a webinar by some leaders recently, and they were talking about this phrase, "You can't pour from an empty glass," really emphasizing the importance of self-care. And I think it was at times quite difficult. And I think, there were some people who were very anxious, very stressed. So one of the things I did was to reduce each length of line management supervision, but made it more frequent. So I was trying to touch base with everybody every couple of weeks, and then the emphasis probably shifted from things like caseload supervision, really to ensure people's well-being for months.
Yeah, okay. Well, I was going to say just about in terms of evolved the importance of the electronic patient records that we, also very much guided by you, Yoko, in terms of that people were absolutely sure that we were updated and with a clear grid care plan and the RAG rating, like you said before, because that guided very much sort of proactivity and how, in terms of contacting people for welfare calls. As I said, some welfare calls and safety calls, especially regarding safeguarding and checking for connections and links with the social care. And we in some ways, really, a lot of things got tighter, really, in terms of MDT, making sure that we had a weekly MDT clinic discussion and everybody had that supervision. So in some ways, really, some of the changes that needed to do actually were sped up, really, because we needed to have that in place. I talked about the safety of the building. The challenge of new assessment, I think it was something that some people talked about in relation to new assessments. But normally we would do a face-to-face, coming to the clinic or elsewhere, really. But this time, the challenges of actually meeting or talking to someone, either over the phone or Zoom, for the first time, a new assessment. So that is challenging because we hadn't done this before. And there are some projects that are being developed. Like I said before, some are put on hold, but others have started. Like there is a QI project looking into the practice of the very practice that we are just going through, like remote working and working from home. I think this is going to guide and organize our thinking for future work, really. And we had to be speeded up with consent for the practice that we started to do.
Yeah.
Family systemic, do you want to say about that?
Yeah, so just after the previous slide, so interestingly, there are a couple of questions about what changes would you like to keep permanently, and it's a really good question, I think, because one of the things Eduardo and I have been thinking about is what we are learning from this episode and what are the things we would like to develop innovate and then keep. So interestingly, we have been working on, so for example, team processes, admin processes, and we have been able to use sort of phrase signed, sent and signed to avoid delay with quite a lot of negotiation with the admin team. But very quickly, our letter sending became entirely that, because very few people are in to sign the letters. And also we actually actively try to reduce the traffic into the admin office, because it's already a shared office and we really didn't want to expose our admin staff to unnecessary risk. So some of these things I think we can keep, and also things like consent, how to upload it. I think it had been already an admin process to simplify it, but this process meant that we could gain consent to email people to send the Zoom links verbally over the phone, because otherwise we just can't even send an invite. So there was clear guidance as to how we need to speak to people on the phone initially, explain the Zoom, explain safeguards we're using, and so on. And then there have been numerous emails about how we ensure security, and so on and on and on. And then I'm actually very pleased to say most clients were quite happy to use Zoom. And Eduardo, you were saying that some clients were actually even more talkative, interestingly.
Well, I thought, I mean, we, not just me, but a lot of talking to different people, that we began, started to see a lot of creativity and different approaches. One is that I could see that some young people, could talk more or talk in a different way. They, when they didn't see you. And I remember a situation with a potential ASD assessment where he was actually very different from what I had been told before in terms of this young person, how she interacted. So who knows really whether it was partly to do with the phone, but I mean, I'm talking in terms of creativity and flexibility. The two examples that come to mind, one was when, to use like your discipline, Yoko, in terms of family therapy, when you are with a family in front of you with a Zoom, and there's two therapists really, and you ask the family to listen for a minute or so to the two clinicians talking to each other. That was quite interesting, really, to have a family in front of you, everybody looking, towards the screen or towards each other. Sometimes you have families sort of close because one camera, really, one gadget, and listening to the reflection, really, about what had been discussed. So that was one interesting aspect.
Yeah.
Another one was this issue of having to set up sometimes network meetings right at the beginning. I had a meeting in a large room. We didn't know much yet about, it was just before lockdown. But we ended up having 3 mobiles on the table, really, and people connecting because we didn't have a landline in that room. So it's just issues, really, about flexibility and creativity.
Yeah, absolutely. So I have to give our head of discipline, Sarah Helps, a lot of credit on developing protocols, and I think she's doing QI on family therapy practice. So probably we are in a unique position where, so my team alone has 3 family therapy teams serving the master's level family therapy training teams. So each team had a different circumstances. So for example, mine kind of fell apart a bit because two of my team members had to be redeployed and we couldn't meet regularly. But the other 2 who could actually still meet, I was still live supervising, and then we kind of worked out with families. So some of the families had been in the clinic with one-way screen, so I explained that I will switch on my video and I'll be invisible when I'm actually in the background. And then when I offer reflection after being invited by the therapist or the family, I would make myself visible. And so my team actually haven't tried it as yet, but many other family therapy teams, as Eduardo said, actually just carried on family therapy. And they're reporting that it worked quite well. So in terms of the clinical work, we actually haven't had to suspend any work. And we are quite fortunate that we are well funded, well resourced CAMHS, and we didn't have to suspend any of the other green-blue cases. However, there was a period that there was a direction within the department that we need to warn families that if we get swamped by high-risk cases, and there was also a possibility that some of us would be redeployed to crisis hub. It didn't happen in the end. You know, we might actually have quite significant reduction in staffing. So we decided as a team that we have to kind of gently warn families that we'll carry on, but there is a possibility that we may not be able to meet with them as often as we usually do. And I'm aware that other CAMHS may have had to make these different decisions. And recently we actually reversed that decision because the referrals just gone right down. So for a period, we were actually telling blue and green families, well, would you like to come back in September? And
Yeah.
I actually contacted them again to say we are actually business as usual. But again, that might change because we may have a surge in future. So we are kind of maintaining stance that and we'll be always prepared.
Okay.
And then we will prioritize cases based on risk and urgency.
Yoko, I'm just aware of the time. I'm not sure. I mean, I think we okay. Maybe if Aaron gives us the heads up, but I'm just maybe gonna move on and maybe give an outline of some of these the next lines rather than in detail because of time, and so we have time for questions really.
Eduardo, if I could just cut in there for a couple of minutes, just to say, if you could maybe finish up on the presentation in say let's say the next 5 or 10 minutes. What we'll do is we've had quite a lot of questions, and perhaps what we could do is make space for it through a recorded session that we can upload to the website after, just so that we can make sure we give all the questions as much time as we can to allow you to get through them. But I'll hand back over to you for now.
Great. Okay, so I'm just going to squeeze through some of these and just say one line that maybe a lot of psychotherapy that talked about the lack of, you know, the nuances that happens in a consulting room. In terms of psychiatry, there was, well, we thought there was going to be a surge in medication usage that did not happen. We had to adjust the issue of giving medication or the prescription really, but it became over the post. Mainly, really, or the more controlled drugs, people would have to come. In terms of supervision, things were happening with via Zoom, and I think it helped the fact that we could share the screen. So I'm just going to go, and we need to remember that there is an interface with the acute sector that themselves saw a very drop in referrals and presentations, but there was a lot of readjustments to be made in North Central London. I think that we learning really that the importance of staying steady, having clarity about the task, and whether actually beginning to learn whether it's easier or faster to do some communication online. That's what Yoko was saying before, and the importance of proactivity, very much the importance of continuing the service and support all of us, you know, doing that. The importance of how much about praise and recognition to one's professional development. Again, you know, about we became more aware of our limits and limitations. Very much, this is really high up, really looking after oneself, the need for breaks and having the right chair, and the need for time and space to reflect. Well, I think we are beginning to think about, and we'll continue about the service delivery and the configuration. This is maybe part of the QI. Very much how do we collaborate and with different agencies like social care. I think commissioning are beginning to think about whether it's going to change. I think even the QNCC, this is a new phase, really can begin to think about what's the implication for QNCC standards. And risk, needless to say that it's a challenge really to think about risk in relation to the new practice, but that's something that we are continue to think about. And for those listening and with ideas, I came across this at NHS England and improvement. They are looking to capture what innovations, different practices that people are doing. So they are keen to listen, you know, to hear from everybody. So that was a speedy one, wasn't it, Aaron?
Lovely, thank you, Eduardo and Yoko. As I said earlier on, we've come up to time, unfortunately, for today's session, which means we haven't actually made any space for Q&A, but we have had about 12 questions come through while you've been presenting, and we want to make sure you give as much time to those questions. So what we'll be thinking about doing is recording a session offline, which we can upload onto the website at a later date. And that way you can answer all of those questions for all of our members that are watching today. Thank you for all those who have watched today. We have a new online discussion platform called Knowledge Hub, which we'll be posting questions onto our dedicated COVID-19 mental health improvement network. And there is also a dedicated online forum for QNCC. This will allow you to view and take part and post in discussions. We'll also be shortly be uploading this session onto the CCQI webinars webpage. If you are interested in presenting a similar webinar session, please do get in touch with the team via our email address qncc@rcpsych.ac.uk. Thank you for everyone for joining us today. We hope you found the session helpful, and we hope you all have a lovely afternoon. Thank you, Eduardo and Yoko, for the session we've just had. Unfortunately, we didn't manage to get through the Q&A with the time that we had for the session itself. So we've set aside some time to go through some of those questions. So if I start with the first one, you accept referrals up until age 17. Does that mean adult services take referrals from age 17?
Yeah, so I can take that question. I have to apologize, maybe it was a bit misleading. What I meant was we work with young people after their 18th birthday, and then we usually transfer cases. And adult services usually start taking cases from the age 18.
Perfect.
Yeah.
Okay, and then question 2, do you do neurodevelopmental assessments? If so, how are you doing them in COVID-19 times? For example, children's observations.
Interesting. Yes, the short answer is yes, we do. There is a service called SCAS, the Social Communication Assessment Service, and Mosaic for Connection is a parallel service for learning disabilities, and they do, and they stopped right at the beginning. There was a pause, but they are going back to it, and they are doing the same way that we are also doing other assessments, either over the phone or on screen via Zoom. And the observations, of course, is challenging because the schools were closed, but they are going to be back on doing, as within reason, of course, bearing in mind the safety. But they also do, when they do the Zoom session at home or any other place, they do the observations. But the short answer is yes, it's actually back doing the assessments, and we do the neurodevelopmental assessments.
Excellent. Did your team or organisation fully support remote working so patients could still access the service provided by certain clinicians? What views or advice would you have if a team or organisation is still not facilitating working remotely?
I'll start, and maybe you could add, Eduardo. So yes, I feel that we are fully supported by the organisation. The decision was made very quickly that Zoom will be the platform we will use. So my understanding is that Zoom was actually used by training department prior to this COVID episode. So it seems if that was actually choice the trust made, and it's worked really well for us. I suppose my advice would be any service is better than no service. So there may be some compromises. There may be some cases where face-to-face may be preferable, but our stance was we just wanted to carry on with the service, and I think we successfully have done. I mean, in terms of compromise and challenges, one of the challenges was the fact that our local authority colleagues are not allowed to use Zoom. So we had to kind of juggle different platforms such as Skype and then Microsoft Teams. I think we got there in the end. And there was a bit of trial and error. So there was a trust-wide message that we could use WhatsApp for video session. And the decision was reversed within a few days because some young people apparently recorded sessions and put them on the internet. So I think we have learned enormous amount along the way.
Yeah, just to add laptops that you know, if I think the question was also about if the organization is not supporting, but I think they may be trying to, you know, if it's an IT issue, because some organizations, I think, including here, really, there was one point there were people not laptop, but we made an effort, a push for people to have laptops and access to that. And yeah, it'll be interesting to think about it also in terms of environment, in terms of distance, whether organizations are pushing for people to be present, whether they can provide good enough environment in order for people to come in.
Yeah, and I think another crucial issue is whether clients have access to laptops or any devices, and also crucially internet connection. So I must say our patch, North Camden, is a relatively wealthy area. I personally haven't encountered any difficulties, but I'm aware that there were some cases where families found it quite difficult to access services. So we were told by a business manager that some laptops were donated to the trust for used by our clients. So it may be that we will need that sort of development in future.
Okay.
There was also one example where a family therapy team absolutely determined to carry on, but the family didn't have any internet connection or laptop. So the family was passing around the mobile phone between themselves, but they were absolutely grateful for the service they were receiving. So I have a sense that the clients did their best to access service when they wished, and I think our service responded the best we could.
Excellent. So the next question is, what additional support did you provide staff with in terms of their well-being?
I can respond to that in part, and Eduardo, please do add. So there was information about employee assistance program, which had obviously pre-existed COVID, but there was communication around that if people chose to access it. But staff well-being was probably one of the biggest things we have been thinking about. So one example of how we try to give people a voice to talk, especially at the beginning. I think the level of anxiety was so high that a small number of people who were particularly vocal often dominated the meetings, and I noticed that there are lots of people who are silent. So this was an idea given to me by my clinical supervisor, and then I started to do what's called a ritual of inclusion. So I explained to the team that each person will have 1 minute to give any updates, or they can share anything they wish. It could be a moan question, if they wish to share something inspiring they heard about, something they were proud of having done, anything really, to make sure that everyone actually spoke. I think we kind of naturally sort of went with the flow, and I don't think we enforced it until recently, but there was a point where I really thought that it was very important for everyone to have some kind of a voice.
Can I just add that we have, which seems to be like a twice weekly newsletter. One is a big one called the Communications from the Trust, highlighting what activities and what meetings is still present really, and what can be done. And maybe important to remember really that there have been really some support also for some of the groups that have been especially affected, and we are now beginning to see more evidence. And for example, the BME network continues is actually beginning to be back now, and some of the other results that Yoko mentioned earlier about the podcast for staff. So it's about connection and connecting online through the emails that you had to see through to actually see what was available to yourself or to your particular group where you belong to.
I also had a sense that sometimes just silence or lack of communication itself was really not very helpful. So some of the times I wasn't really sure what the update was, but then I was kind of trying to convey that I don't know, but then there's an ongoing discussion, so something like that. And people, often really wanted more information, more connection with the higher level of management. So people like us who are in between the senior management and staff group, we really needed to pay particular attention to communication.
Okay, so the next question is, how are you supporting family anxiety around COVID-19?
Well, we in different ways really. We rug rated, made a push for everybody to rug rate their caseloads, and make also a push thinking together to phone everybody as much as possible to actually be proactive about our caseloads, and initially asking about not just about the reasons why they were connected to us, but also about the COVID, and thinking about any concerns or anxieties that actually they had about the COVID, but also about the extended families. And it was very interesting. A lot of people, even before we asked, that's what they wanted to talk and ask us questions. And we could also use some of the knowledge and some of the dissemination of information that we had from the trust to the families about COVID, and trying to reassure them really with data and information. I think we also have some of the resources, which I think is on the last slide that you will upload, Aaron. There are some resources for families that they can access, and so we were sharing with them for them to access some of those resources.
I mean, another thing we reflected on is the fact that quite a number of young people and families were actually reporting that they were doing better. So we couldn't really make a simple assumption that they were affected adversely by COVID. So, you know, for example, I had a young person with social anxiety, and without school, you know, she's just getting on with her studies. She seemed to be coping a lot better. So that was quite interesting. So really being having an opportunity to talk with each client and family and get a sense of how they're doing, and just let them know that if anything gets worse, they can contact us. So currently what we are probably a bit more worried about is what it's like for young people who have been doing better at home, for them to have to go back to school. So that could be, you know, at a time when young people's anxiety might actually escalate.
But then if you think about that, something we thought that the COVID was, as we said, and what was shown on the one of the first slides, is as much as an infectious diseases and what happened, but as much as that, as well as a sense of unpredictability, uncertainty, feeling vulnerable, feeling the sense of mortality, and also some of the parents were perhaps feeling quite uncontained by, you know, like us. So, but we had the luxury, let's put it this way, of having one another really, and thinking about that in a professional but also personal way. So by sharing some of that with the family, I feel that a lot of families feel actually quite helped really by voicing some of those anxieties that are COVID related, but not necessarily just with COVID.
Lovely. So this question also ties in with the previous question. Have staff been wearing PPE equipment, and how have young people reacted to things like masks?
Could be short. Yes, as of recently, yeah, for like Yoko said before, but especially for risk, for red rated cases, and they are beginning to have face-to-face appointments. PPE, yes, and staff have reporting, like we heard elsewhere, really hugely warm and heat and sweaty. I think we just heard actually recently, this last May, the last few weeks has been the hottest spring on record. And so it's been quite hot actually. So we can well imagine and just spare a thought for people in the hospitals really. But it is with a degree of, I don't know, trepidation. Young people, they feedback that yeah, it's quite unusual, really, very unusual. But people are getting used to, and everybody's amazed at how quickly people get used to, although it's really far from comfortable.
we had a staff member who fed back that it was really good to be able to see the body language of the young person and family, and he wondered he may not have picked up on some of the things without being able to see that. So I think there are pros and cons to both clinic-based approach with PPE on ourselves and also sometimes clients. So if clients are wearing masks, obviously we can't really see half their faces, but also some clinicians were talking about clients actually not taking up on the offer of masks, and one of them coughed. So that actually, you know, made the clinician feel quite nervous, really. So I think it's a difficult balance. I think we're lucky to have a couple of rooms we're using, which I believe has aircon, and we've been told we can switch it on. But I think it's a really major consideration for both our staff and clients, whether it's the environment is comfortable enough.
Okay, so the next question, are there any new ways of working you have implemented which you might consider more permanently to work with and reach out to young people and their families?
I think the short answer is yes, and I think we are learning as we go along, really, to be honest. We are learning a lot about, I think one thought it comes to mind really is that we're going to be learning about different types of presentations and different types of young people who feel more comfortable with that approach or not approach, but also how to reach young people. And I mean, in some ways, really, some of the work was already been happening anyway with, say, crisis teams. There had been many teams up and down the country who had been using already mobile phones and outreach services anyway. I think maybe what's now new is whether we're going to establish some of that to the community services, where we usually invite families and young people to come to the clinics. And I think the short answer is yes, really. We don't know yet how, but I think it will come in their way. Not only that, but also we're beginning to notice how speedier network meetings can be set up, and you don't need to travel really to places. And I can see an increase in uptake in actually network attendance. You know, early today I was part of a meeting that I believe really, and we were talking actually about that if we had done that meeting in face-to-face, it would be maybe 3 or 4 people for various reasons, but it was 8 today, so people could attend the meeting. So watch that space, because I think the answer is yes. Anything to add, Yoko?
Yeah, I entirely agree. I mean, in order to get the local authority venue from here, for example, it takes 40 to 45 minutes. And if it's in the middle of the day, it actually really eats into your day, which might make it really hard for you to attend. So and also our Camden CAMHS colleagues, some of the people working from other venues, and I have to spend a lot of time traveling here. So in that sense, I think there is a lot of scope for team meetings and also network meetings as well. We usually struggle to fit into the limited space here at Tavistock, because there's just so much competition for large rooms to have team meetings. And I've always worried that you know, how crammed it is actually makes it look like we're not very welcoming to some of the part of the team who only visit every now and then. So it's interesting. It kind of levels the space issues, which is a huge commodity here. Another thing I've been thinking about is how we as community teams need to become more visible in the community, and how we actually make that connection. So one of the worries we had was that because there was such strong message that you know, don't go to hospitals, we're worried that people may not be accessing services because they feel that, you know, they can't go to the GP to seek referral. And then we realized that it's so hard to find on now trust the website how to make a self-referral, and some of us looked at the website and we just couldn't find it. So we basically redesigned it and then made it a lot more well, a lot easier to access it, and also to make it look more friendly. And also the commissioners and the service lead discussed the need for advertising our services as business as usual. So we put that information into Camden New Journal, and we just to say that we are open. And we are now planning to write an article for that Camden New Journal, really to make it friendly and then make it accessible, really. And we are also hoping to maintain contact with our school colleagues, because if we are to be accessible, that's really important link.
Okay, so the next question, are you doing therapeutic interventions or modalities on Zoom or video platforms? What is the feedback from clinicians and families?
Yes, very much so. People have continued actually doing both, actually all modalities, psychodynamic, CBT, family therapy, like Yoko said. I think that maybe there have been mixed feedback. If you think about the more sort of more psychodynamic psychotherapy, that needed a lot of thinking because of partly to do with the setting and also to do with, of course, the connection with a young person in the room. And like we were alluded to early on in terms of the nuances, you know, the body language. So all of that was in a way lost with the lack of face-to-face appointments. But most of people moved to either phone or Zoom, and which raised other issues in terms of privacy, in terms of connection, even actually IT in the houses. Also need to, you know, another issue they needed to think about was about risk, because if you go into more sort of tricky or risky aspects of the session, so they needed to have access to an adult, you know, in the premises. So all of that had to be thought about, but at the same time, you need to, you know, I think we need to think about there are young people who are not necessarily in more like a formal therapy. They are in work, in a therapeutic relationship. That some of them, they actually may are enjoying the flexibility really of previously face-to-face and now phone or Zoom, and that is linking with the previous question. That may be something that we will think about for the future.
Yeah, as far as I know, I've been absolutely impressed with my team colleagues' speed and also willingness to think about different ways of working and be really flexible and finding ways to work with each family. So some young people or families didn't like Zoom. They don't want to see themselves on the screen, but they would accept phone. So we kind of started to routinely ask what this family can make use of. So I heard colleagues talk about some cases which are harder to engage. So some colleagues spoke of how hard it is to do under fives work, where I would assume that much of the work is really to intervene with the interaction between the small children and their parents. That seems a lot harder because you just can't see. You might be able to see some through Zoom, but not entirely in the whole room. And yeah, but I would say that the most work continued. So as I said earlier, I'm doing the scoping of number of cases and the reasons why young people and the families are not able to access services at the moment at the department's direction. And it's a very small number. We have hundreds of cases open to us, and I'm talking about something like probably under 15 cases. Some on waiting list for new assessments, some on waiting list for intervention. But we've spoken to all of these families, and then some of them are saying, well, it doesn't really matter how long it takes, but I just want face-to-face. And in some cases, we had to shift the intervention. So there was an example of a young person who is absolutely adamant about wanting face-to-face, but the parent was happy to receive some parent support. So yeah, we are trying to be flexible as we can.
Just to remind that the population that we are dealing with and offering those interventions are far more used to screens and that kind of work and relating to people than the population offering those interventions. So that's quite important to remember, really, that you know, in a different language, really, the difference between the natives and the migrants with IT. So
So this next question flips the previous question on its head. So have you paused any therapeutic interventions, and how or when do you plan to start these again, or what needs to happen for you to restart these?
I think we sort of covered on the question before, didn't we? I think they have continued. Most, by and large, really would be the exception. I don't know if I heard of anyone who actually had to stop. I think obstacles were basically thought about and trying to overcome, really. I think, yes, we have continued.
Excellent. So next question is, do you have a plan about how you will begin to see or video consultation with green cases?
So we are already seeing green cases. We started to see them for new assessments, and most of the treatment work has carried on. And in terms of time frame as to the usual service, so I understand the questions about video work. So in terms of video work, we are doing all the services more or less as usual. So I think that the next step of the challenge we are aware of is how to bring back some of the face-to-face work, how to do it safely. So so it's not just about our team, but there is trust-wide planning and assessment of the building. So for example, how many clients and how many staff members can we actually have in the building at any given time? Because it's a really busy building with lots of teaching going on, numerous clinical teams working from here. And so for example, for shared offices, the recent information I heard from the estate was that if it's the usual shared office for 10, that can only take 4. So it may be that we have to kind of operate some kind of rota system for some staff to come in some of the time. There is a talk of changing opening hours for teams to 8 to 8, to partly to enable staff to stagger the travelling time, but also to kind of stagger a client appointments. But that would again pose a lot of challenges. For example, when do we have team meetings, and then when do I have supervision, with people? So it may be practical considerations as to how to bring back the service, but it's a really long-term planning, I think.
Excellent. And so we've reached our final question for today. How do you make decisions on which young people to assess via face-to-face or video conference?
Well, it's a combination of factors. I think we've been talking about that as we went along today, but is around RAG rating, risk, possibly the need, and it's very much on a case-by-case situation. I think we consult, maybe talk to colleagues and the network, and usually the referrer, trying to understand the need for someone to have the face-to-face, but usually it will be around the risk. At this point, as I think we tried to highlight it today, things are changing really, really fast. So maybe in 2 weeks' time will be slightly different, but at this moment is based on risk, and risk that could be not necessarily just risk to the person, him or herself, but also risk to other people or any other risk related to the case.
Yeah, I entirely agree. We are probably in a fortunate position that we have other teams, one team which exclusively deal with the child protection cases, so deal with high risk end of safeguarding issues, and also we have another team who work intensively with adolescents, and again they deal with high level of mental health risk. And I'm aware that they are seeing clients face to face, not all the time, but some of the time, again, depending on risk. And then our team is doing the same.
Yeah, I mean, the last thing that came to mind really was that we have already had several situations like that. But then in practice, when we talk to the young person or to the family and or the network around him or her, a lot of the issues that were raised needing face-to-face could be addressed on a non-face-to-face. So, but we didn't have much time today, but to talk about the interface between the community and the acute sector, because there has been a recent increase in people presenting to A&Es and in an acute crisis. say out of hours and weekends. So those presentations perhaps are now beginning to have more priority as well, really, in terms of a linking with crisis teams and us. So presentations like that are likely to be high on the spectrum, really, in terms of face-to-face.
Excellent. Thank you, Yoko and Eduardo, for the webinar session today, and also for putting some time aside this afternoon to answer the Q&A session. We'll be uploading the questions up to the website so everyone can view it there. But I just want to end off by just saying a big thank you to you both for the time that you've given up to us today.
Pleasure. Thank you very much, Aaron.
Bye-bye.
Bye.